Hi all, this is Sarah Banchevsky, the data manager with CPCQC, and I'm going to show you today how to enter your data for Spark. This is updated since the pilot data was collected. We have made some little changes to the form, particularly for race ethnicity, as we standardize how we collect that across all of our QI programs and all of our hospitals. So just note that's a bit different, and this is how we're collecting data from basically January 2026 onward. So you'll come into REDCap using this address here. You will need a CPCQC associated REDCap account and then access to this Spark postpartum care project. To get that, you can email me at data@cpcqc.org and I will get you set up within REDCap. Then you'll come into your project, and on the left side here, data collection, you can either go to record status dashboard, where you are going to see all of the records that your hospital has put in so far. This looks like a lot because I'm viewing all of the different records across all hospitals. You will just see your own. And you can add a new record. And then you'll be prompted to select which data collection instrument and time period you're entering data for. So the readiness assessment is just kind of this time 1 and time 2. And the data capabilities survey was a one-time survey at the start. You're really focused here on this Spark quarterly data entry. Here's our pilot that some of you participated in, and thank you very much for doing that. I hope that it was helpful for you. It was helpful for us. And then this will be your first official data that's due for that last quarter of 2025, due at some point in January. You can check with your QI advisor on when that's due. So you'll click here and you'll be taken to the form. And we are asking for a variety of information here. And there's a set of instructions at the beginning that I recommend reading about what it is we're looking for, what we're asking for. But basically, we want to understand the total maternal discharges following a live birth, as well as the total number of screens for SSDOH, PMHC, and interpersonal violence using a validated tool during that last quarter. What makes this challenging is that for all of our QI programs, we also want this information disaggregated by race, ethnicity, and primary payer to support, to identify and then strengthen equitable care for birthing individuals. And that can often be where some hospitals have challenges surfacing this information. And we do recommend working with your internal IT teams or people, an informaticist, or anyone else in your hospital who can help build reports to surface this information in a way that makes it easier for data entry. And that is part of the quality improvement work that we're doing together. We understand that that might be challenging for some of our hospitals to get to us in the first couple quarters of data collection, and that's part of the work we're doing together. We have this attachment that shows race and ethnicity definitions that will be used throughout this tool, and I recommend checking that out. I'm just going to show you right here really quickly what it looks like. And this is giving you a sense of, for each of these race categories and ethnicity categories, what is the definition? What groups fall into this group? And my understanding is some of our hospitals have very detailed information about racial groups. And so some of the work will be simply rolling those up into these broader categories that we are collecting here on the left. We are going to ask about American Indian or Alaska Native, Asian, Black or African American, Middle Eastern or North African, Native Hawaiian or Pacific Islander, white. Other race cannot be rolled up into the categories above. Patient declined or refused to disclose their race, and then not documented or unknown. It's not in the system, we just don't know. Then ethnicity, we have Hispanic or Latino, not Hispanic or Latino, and again, patient declined or refused or not documented or unknown. And so what we're hoping we can do, we're hoping this is fairly comprehensive, that it is not too many fields to enter, and that we have a space available for capturing and tracking whether it's not being documented in the EHR or whether patients are declining or refusing. And that's something we can work on in QI, is trying to have more consistent documentation. So back to our form. When you enter the total maternal discharges, like if you just scroll through this initially, it doesn't look too long. But once you plug in that you had maybe 20 maternal discharges for the past quarter, these additional data fields pop up where we ask for that broken out by race, ethnicity, and payer. The main things I want to point out are that instead of leaving a field blank, please put 0 if there are none. And then also for race, an individual can be multiracial, can be more than one of these identities. So you might end up with a higher count than like the total maternal discharges if somebody is multiracial. So if a person is more than one category, count each category that is selected. Then for ethnicity, this one in theory should kind of add up to the total maternal discharges because it's exclusive categories. Finally, we have payer. We do ask that if there is more than one insurance indicated, please use the primary insurance. And we've got Medicaid, Medicaid plans, private insurance, other public insurance, and uninsured. And then we go through the same pattern for each of the screens. So social and structural drivers or determinants of health, you'll fill in that, and it really should not exceed the number of maternal discharges. There shouldn't be more people screened than discharged. So you will get a warning about it. It won't force you to change it, but it does pop up a warning, like if you say 30 people were screened, but 20 people were discharged. Then you can enter the SSDOH screenings by race and by ethnicity. And I guess I would say, like, we do recommend putting 0 for everything if it's missing, but please have a conversation with me and or your QI advisor if your hospital is struggling to enter this information at all. And if it cannot be surfaced, that's something we would like to know. In addition to seeing like zeros across each of these, we would like to know that really it's something that currently cannot be found in the system, so that we can work on that together. And then we've got ethnicity and payer, and it's just the same pattern again. For perinatal mental health conditions, how many were screened with a validated tool? And of that, how many belonged to each of these race groups, ethnicity groups, and payer? Finally, interpersonal violence. How many were screened with a validated tool for interpersonal violence? And let's break that out by race, ethnicity, and payer. Ultimately, why are we asking all this information? It is to really look at the percent of folks that are being screened for these critical things after they have a live birth, tracking the screening rates over time, working to increase those screening rates so that we can, hopefully get resources and help to the folks who screen positive. And then the reason we look for these disaggregated fields as well is long-term, we can start to look at, are we seeing similar screening rates regardless of an individual's race, ethnicity, and payer? Ideally, people are getting similar treatment and similar screening rates regardless of these identities and their payer. So that is part of the quality improvement work we'll be doing. Lastly, we ask at the very end here, has there been a multidisciplinary work group meeting in the past quarter, yes or no? And finally, this is really for your own internal use, this complete status. So if you feel like this is done, you can mark it complete. In your record status dashboard in REDCap, it will then show as green rather than red. And if you leave it as incomplete, that might mean I got to come back in here and get some help with some of this disaggregation. And that could be something you fill in even, months later. You can always revisit records and update them to be as accurate as possible. So if you want to have some fields looked at, somebody else look at something, you might leave it as incomplete. Unverified, I don't really see people use often, but I could imagine using that if you enter the data to your best of your ability and you want someone else on your team potentially to check it. You could use the unverified field. We don't really do anything with this. We don't, on our end, if a form is marked as incomplete, we still process it. It still shows up in your data dashboard. So again, it's really for your own internal use. When you're done, you can save and exit the form or save and exit the record. Either way, I think it's going to take you back. Well, first, it's going to be mad at me that I didn't fill in all of these fields. So there is a setup in here where we are quote unquote requiring fields. It simply gives you this warning. It doesn't actually force you to enter the data, but it will show you any fields that are missing. And this is part of why we say, please put 0 rather than leave a field blank. So you can ignore and leave record. If you click OK, it's going to take you right back into that form to fill in those fields that are missing. For now, I'm going to ignore and leave the record. And it brings me back here. And you can see now that we have this incomplete record because I left it as incomplete for October through December. And that's it. That is how you go about entering your data for Spark. I hope that this was helpful. Again, if you need me, if you have questions on this or need me for data support or data access, you can reach me at data@cpcqc.org.